Thanks for joining our presentation. Philadelphia International Medicine's Global Education Media Program is a monthly digital platform that invites physicians from around the world to exchange knowledge and innovative uses of medical technology, review the latest advancements in research and clinical care, and share best practices in case reviews. To contact our presenter, refer a patient, or more information, email physicians@philadelphiamedicine.com. Follow PIM's YouTube channel for more educational videos.
To introduce myself. So I'm a GI oncologist, associate professor at Fox Chase Cancer Center. I've been here just about 10 years. I came here from Columbia University and did my fellowship training at University of Chicago. And my training before that at Harvard and at Columbia for medical school. My expertise is, as I said, in GI cancers. I particularly see a lot of early onset and young colorectal and pancreatic cancers. That's mainly because my sort of other hat is in hereditary genetics and risk assessment of families and individuals who are at increased genetic risk of cancer. So my talk today actually focuses on that specialty, on hereditary aspects, and I particularly want to focus today on colon cancer. This is a world that has really advanced a lot in recent years, but I think even still some of the fundamentals can be challenging for people to remember and to separate in their brains. And so that's what I'm going to try to cover today in the next 45 minutes or so, and then we'll have time for some questions at the end. So when we think about hereditary colorectal cancer, I thought I should say it, I didn't put a disclosure slide, but I do quite a bit of collaborative work with various companies, including Myriad Genetics, Invitae, Caris, Foundation Medicine. This is all collaborative research. None of it is for pay. I don't receive any unrestricted funds, and I'm not on any sort of speaker boards. So this is really just all research relationships in a collaborative setting. So to start the talk, hereditary colon cancer and how do we think about hereditary colon cancer? So our biggest initial distinguishing factor is this a hereditary colon cancer picture that looks like it is dominated by having polyps or not having polyps. So that's kind of the first major break in our pathway. And when we look at the polyp pathway on the screen, you can see going down to the left, we first think about the type of polyps, and I'll get into the hamartomatous versus the adenomatous syndromes in a minute. Or we think about hereditary cancer where there's not polyps, and then we think more about, of course, what is the most common cause of hereditary colorectal cancer, which is Lynch syndrome. And so we're going to first start talking about Lynch syndrome because it is common, it is highly underdiagnosed, and it is a syndrome that really everyone, both in primary care and in oncology, should know something about. So Lynch syndrome affects about 1.2 million Americans in the U.S. This makes this really one of the most common hereditary colorectal cancer and, frankly, cancer syndromes that we treat in this country and that we should be recognizing. So this has an inherited risk of not only colon cancer, but endometrial cancer, ovarian cancer, gastric cancer. There are skin findings. A recent abstract at our National Oncology Meeting, ASCO 2018, from Memorial Sloan Kettering showed that, in fact, this syndrome can cause many variety of cancers. The most common ones are the ones I show up here, but actually this syndrome underlies many cancers that are forming in the population. And so there really is strong rationale for us to identify people who have this so we can screen people appropriately. The most important part of that, of course, is that these aren't just cancers that are going to sort of kill you without being able to do anything. These are actually preventable cancers, and of course, colon cancer is the poster child for that. But also endometrial cancer, ovarian cancer, stomach cancer. These are all things that some of the skin findings are all things that, with knowledge and with awareness, we can prevent many of the manifestations of this, and people can clearly live a normal lifespan if they are aware that they have this syndrome. The problem is the awareness, and 95% of people who have this, our current estimates are 95% of people have no idea. The syndrome that is sort of most known in this country, probably because of support from Women's Health and other reasons, is BRCA. And the BRCA1/2 genes have been highly tested in this country. The estimates are probably, compared to BRCA testing, the volume of Lynch syndrome testing has only been maybe about 10% of that. So Lynch syndrome is way far behind, although it actually is more common. And so we really need to catch up on this, because this is a syndrome where we could do a lot of good if we recognized it. So Lynch syndrome is caused by germline mutations in 4 genes. I'm going to say 4. There's actually sort of a couple others out there, but just to keep things sort of simple and direct, the major genes of Lynch syndrome are the MLH1 gene on chromosome 3, the MSH2 and MSH6 genes on chromosome 2, and then the PMS2 gene. The interesting thing of sort of why there are 4, it's because the protein products that are formed by these genes actually form what we call heterodimers. So the protein product of MLH1 and PMS2 form a composite protein called a heterodimer that work together and do their function of mismatch repair together. At the same time, the MSH2 and MSH6 gene products, the proteins, also form a heterodimer protein that then work together to perform their function in mismatch repair. So that's why you'll see in the coming slides, when we are doing testing on tumors and otherwise, often you'll see losses of those proteins that go together. So just for a couple basics about how hereditary cancers work, there are cancers that, when we're looking at families, look sporadic. Those are where they are often later onset. There's not that much family history. These are often, sort of a single diagnosis later in life. When there are 2 sides to an organ, like the lungs or the kidney, these are often more of the single or unilateral tumors. The ones that, of course, we're more interested in are inherited. And frankly, most of the inherited cancer syndromes we think about, although not all, are autosomal dominant, or ones where we generally will see at least one person in every generation affected. So these tend to be earlier ages of onset. You often will see multiple generations of people with cancer. And then often these people will have multiple primary cancers. And if they have 2 sides to an organ, like the kidney, sometimes you'll have both kidneys affected in these syndromes. One thing I do want to emphasize, though, is that this is never a perfect science. And even with these autosomal dominant genes, the risk, for instance, with the MSH2 gene that you're going to develop colon cancer is only about 80%. And now, even though that's obviously very high, there are going to be 20% of people who are carriers who over their lifetime will never develop colon cancer. So you may get a picture that could look like sort of skipping generations, or you may not have that continuous line of inheritance in a family. And I think you always have to be aware that the word we use for that in genetics is penetrance. So how many people who carry the mutation actually get disease? The penetrance with these genes, none of them is at 100%. So you can always have some people out there who may not actually manifest the disease. And that's always sort of an important piece of information to keep in your mind. Again, just getting back to what I said a minute ago, so these are generally autosomal dominant, meaning with one mutation, obviously we all have 2 copies of all the genes in our body, except the Y and X, but that's sort of slightly different scenario. But everything else, all of our other genes, we have 2 copies, so we have a backup copy of everything. But with these syndromes, you only need 1 copy to be damaged or inherited to have a risk of the syndrome. And what essentially happens is or what we believe happens with the pathogenesis is we all, people who have Lynch syndrome carry around, for instance, a damaged copy of MLH1 or MSH2. And at some point during their lives, one of their colon cells will develop, the classic Knudsen 2-hit hypothesis. So they lose that second allele for some reason, either exposure to some environmental toxin, they ate too many hot dogs, something caused that other gene allele to mutate, and then that sets them up for developing colon cancer because of this risk of not having effective mismatch repair due to loss of the function of that MLH1 gene. So the risks of Lynch syndrome, I will emphasize, we are still actually learning a lot about. So all of these numbers I present, I'll try to qualify them for you where I think our knowledge is best, and then where I think our knowledge is still evolving. The MLH1 and MSH2 genes, which were actually the earlier two genes that we kind of have known more about for longer, are absolutely the two higher risk genes in this syndrome. And so they carry with them risks of colon cancer that are on the order of anywhere from 40 to 80%, as I show here. Endometrial cancer risks appear to be, again, up to about 60%. Stomach cancer risks maybe up to 15%. Ovarian cancer risks maybe as high as 20, 25%. So these two genes, I would say the National Guidelines Committee, which I'm part of, with others, we consider these two genes really the high-risk genes in this syndrome. And if you have individuals in your practice who carry these genes, you really have to sort of treat these. You look at these guidelines that are published and you say, these are the people who clearly you need to follow sort of the strictest guidelines if you want to prevent cancer. The MSH6 gene sort of is sitting in the middle right now, and I want to both give you the best idea of how we think about it right now. I think there are clearly families who carry this gene who have sort of a more moderate penetrance presentation. They seem to, with the numbers that I post here on the screen, they seem to have lower risks of colon cancer. Those colon cancers often seem to happen later in life. Somewhat lower risks of endometrial cancer, and then some of the other, what we say, extracolonic tumors, the stomach, ovarian, some of the others are lower. The kind of gigantic caveat to that is there are absolutely families who carry MSH6 mutations who look a lot more like the MLH1 and MSH2 families. So, for instance, in my practice here at Fox Chase, just a couple weeks ago, we saw a family that had an MSH6 mutation who really, in terms of how severe the disease was in the family, looked very much like an MSH2 family. So whenever we see those families, that kind of lends pause to think, wow, we still are getting a handle on how this gene works and what the intensity of disease is. And it may really boil down to sort of contextuality of mutations, where they appear on the gene. What kind of mutations are they? Are they missense gene mutations that don't truncate the gene but that change the sequence a little bit? How do they affect the proteins that bind to it? So I think, but my bottom line about MSH6 is I think generally we can counsel our patients that the risks seem to be somewhat lower than the other genes, but I think we have to be careful and really look at the family history to help us hone those mutations to families, because there are some families out there where the risks do appear to be higher. The last gene, PMS2, is actually one where we really have, with collection of data over time, discovered that this does appear to be generally a lower risk gene. So the risks of colon cancer are only maybe up to about 20%. Just to contextualize that, the average risk of colon cancer in the U.S. population is 5% over a lifetime. So we're looking at like a 3 to 4-fold increased risk. Endometrial cancer, again, somewhat elevated, but not terribly so. Some of the extracolonic tumors actually appear to be quite rare, if never reported in PMS2. Although, again, in my practice, and certainly in the practice of some of my colleagues, they have seen some stomach cancers and esophageal or lower GE junction tumors with this gene. So things like that can happen. They just are extremely rare. You may, in your practice, hear of one other gene that's called EpCAM. EpCAM is actually a gene that sits just upstream on the chromosome to MSH2. So when you think of EpCAM, just think of that really as being an MSH2 mutation. They tend to function very similarly, although the EpCAM mutations actually do often present with an MSH2 phenotype that's even more severe than the average. So if you ever see someone with an EpCAM mutation, you have to, again, be really aware that these are people who have very high-risk Lynch syndrome. So again, I think hopefully you learned from what I just said on the last slide that even though knowing a mutation is obviously really important with helping us guide families in terms of what's best for their health, family history remains incredibly important, because it helps us find families that are going to be at risk of Lynch syndrome so we know who to test. And then it will also help us really guide families in terms of how they manage the mutation in their family, especially with the genes like the MSH6 and PMS2, where the risks can potentially be a little more variable. So if you see a family like this, for instance, in front of you, this is a very penetrant looking Lynch syndrome family where you have multiple cases of early onset colon cancer. You have an ovarian cancer in a relative, endometrial cancer. So this would be certainly a family that if I saw this family and I had to guess, I would say this looks more like an MLH1 or an MSH2 family because of the high risk of disease in the family, multiple family members getting disease, and then several early onset cases. There are some criteria out there which without dismissing them, I will say have kind of somewhat lost their importance to some degree in terms of how we identify families. But I think it is good to recognize that these criteria were initially developed multiple years ago now to help us kind of screen families to identify those families that may be at higher risk of having HNPCC, which was the old name for Lynch syndrome. So 3 or more relatives with one of the known Lynch syndrome cancers in the family. These should affect 2 or more generations, again, getting to this idea of autosomal dominant. Also, the first degree relative of the other 2 gets at this. Early onset cancer, again, a classic feature of inherited cancer syndromes. Of course, sort of back in the day when we were thinking about these criteria, we really kind of only had sort of 2 syndromes we focused on, FAP, which I'll talk about in a couple minutes, and then Lynch syndrome. So you would want to have excluded FAP at that point. So these were kind of the criteria that we were using and thinking about back in the day when before we had sort of more sophisticated methods and more data on these genes. These were followed historically by development of somewhat more liberal guidelines called the Bethesda guidelines, again, that still had some focus on early onset cancer, but then also began to bring in some of these other features of these tumors. So MSI high histology was recognized as being important. We'll talk a little bit about that in a few minutes, but again, still some focus on strong family history as a way of identifying high-risk families. Again, these are sort of still out there, and if you look at NCCN guidelines, we still include these as ways of sort of generally screening families. These are probably in many ways more useful in the primary care setting where you may have a patient in front of you and you're trying to decide, is this actually a higher risk patient? These can sort of help the provider say, you know, this is probably not a high risk family versus is, but you know, many of the complexities of these guidelines have kind of been surpassed by our ability to sort of cheaply and rapidly test people with multi-gene genetic tests to determine whether they have hereditary risk. Finally, there are these sort of risk calculators, and again, these kind of fall in that same pool as the guidelines that you know, you can sit at your computer in your office and you can pull up the PREM5 model, which is housed at Dana-Farber. You can enter a bunch of data on your patient and their personal history and their family history, and this can generate a risk score or a risk percent for that patient. Again, there's been sort of some debate over time of where you set that risk threshold for who should get tested and who should not. So that threshold used to be 5%. A more recent update from the Dana-Farber group suggested that that threshold should be 2.5%, and we have gently endorsed that lower threshold in the national guidelines. Of course, you know, the important part of setting thresholds is, you know, the more you move the threshold up, the higher you set it, you have greater specificity. The people you find who are positive are much more likely to have the disease, but you're going to lose sensitivity. You're going to have some people who are missed because they're going to have the disease and just have a lower basically percentile score. And then vice versa, as you move that number down, you are going going to have a much greater sensitivity. You're going to pick up a lot more families, but you're also going to lose your specificity. So you will have people who are tested who don't have Lynch syndrome, and that's going to end up, this becomes then a cost issue and an access issue and a resources issue. How many people is it worth testing and having negative testing to find those people who are going to actually be positive? That's kind of beyond the scope of this talk, but I think we have to all think that sort of costs and how we spend our money to diagnose these syndromes is obviously really important, because these things are important. These things are common, so we don't want to miss them in the population, but we don't want to spend all of our money testing people who probably really don't need to be tested. So one important caveat that I think all of us in this business always make to people out there who are kind of on the front lines in their primary care practice or in their oncology practice is you have to remember, you know, I think we've all really learned well in medical school about the importance of family history, but one thing you really have to remember is that family histories can really be deceiving. And one thing that I didn't put on this list is patients are notoriously bad about reporting family history. So sometimes you have to not just sort of ask them in the clinic kind of off the cuff. You have to sort of give them an assignment and maybe a family member who's with them as well to go home and actually talk to people in the family about their family history. Because, you know, even if you ask me sitting in a clinic, my family history in a 30-second ability to answer, I'm not going to come up with all the answers until I probably would, you know, engage my brother and my mother and other people in the family about what has actually happened in the family, because a lot of people just don't know that right off the bat. Other things that are important, as noted here, family size is getting smaller. We're not, you know, sort of seeing these 10 children families with you know, trees that are family trees that are full of branches and leaves anymore. We're seeing things that look more like the Charlie Brown Christmas tree with one branch hanging on it, and this makes it a lot harder, especially, as I said, when you have these less penetrant syndromes. To you may sort of have what looks like skipping of generations or very little family history to go on. So you have to remember that caveat. You have to also remember that colonoscopy uptake in the population has improved, and especially in these colon cancer syndromes where that's the major presenting cancer. If people in a family are actually getting screened and getting polyps taken out, you're not going to have cancers in the family that help fulfill these criteria. And, you know, frankly, at the family reunion, most people aren't necessarily talking about their colonoscopies or what polyps they had removed. So you might, you know, if you really want to find out, you know, if Uncle Charlie has ever had polyps, you might have to really press him on it because you just might not have that history. Another really important thing here is, as I talked about in earlier slides, is MSH6 and PMS2 have lower cancer risks. So you have to remember that you may not see these really striking penetrant family histories like I showed in the pedigree several slides ago. Things like adoption also, which is increasingly common, sperm donation, which is incredibly common these days, and then non-paternity, which is a nice doctor way of saying that the father is not necessarily the father that we thought, or may not be aware that they're not the father. These things are actually really, really common, much more common than you may think, and so you just have to always keep these things in mind when you're evaluating a family history and thinking about whether there could be a gene in the family, because it's not as always as obvious as you may think. So we have one thing I really wanted to focus a lot on today, because it's just something that's so common and something that everyone should really know about, is these tumor tests for Lynch syndrome. So back in 2009, 2010, but even before that, you know, these tests had been developed that can be done, performed on tumors, particularly colon cancers, but now expanded to endometrial, and now with some with immunotherapy, we're actually probably doing these tests on many more kinds of tumors now, but these can be used to screen tumors, particularly colon and endometrial, to see if they are tumors that would be potentially suggestive of Lynch syndrome because of having evidence of mismatch repair. And so there's a few tests out there. I want to just have you focus on the ones on the left, the MSI testing and IHC testing. I'm going to cover these right now, and just so you kind of understand these, I'll say a little bit about the BRAF V600E testing and also something called methylation testing that we do as well. These are just tests that everyone should sort of understand so they know when they should be performed, what they mean, and how they can help us. So I'm going to just show you this graphically first, then I'll show you some example slides. But so what is IHC, or immunohistochemistry? This is staining paraffin prepared slides of the tumor. For this kind of testing to work, you actually have to, on the slide, have not only tumor, but there has to actually be some normal tissue there as well. So there's actually a comparator. And essentially what immunohistochemistry does is applies these different monoclonal antibody stains to the tumor, and they are for each of these different proteins, the MLH1, MSH2, MSH6, and PMS2. We would expect in normal healthy tissue that these should all be expressed. Of course, as I told you before, in a Lynch syndrome tumor, you're going to expect that some of these are going to be deactivated or missing. And they tend to happen in pairs, again, because of that heterodimer phenomena that I told you about. So here on the left, you see the patient who had the slides prepared, and the normal tissue on the slide shows expression of all the tumor, of all the proteins. But on the bottom, we see normal expression of the MLH1 and PMS2, but there's no staining on the MSH2 or MSH6, indicating that there is some potential defect or loss of protein. We don't really know from this whether it's the 2 or 6, because again, when one of them is missing and destabilized, the protein heterodimer is unstable. So if you have a mutation in 2 and you don't have that protein formed, actually the MSH6 protein that is formed normally also is not stable, so you don't actually see either one on this testing. So that's one thing to keep in mind as well. The other test we use on the right is microsatellite instability. So this is a completely different technology. This is usually a PCR-based test where you're basically, again, you need both a normal control and you need the tumor, and there are these 5 regions of the genome, these 5 microsatellites that I list up here: BAT25, BAT26. These are the names of them. And what we do is you do PCR sequencing of the length of these DNA repeat regions. So these are regions where you have a particular nucleotide, like glycine or something where there's a repeat, like a GGGG, or maybe a dinucleotide repeat like CG. So in those repeat regions, you have greater chance that someone who has deficient mismatch repair is that the cell is going to make a mistake in terms of replicating the cell during division, and so you may have alleles that are slightly different in length because of deficient mismatch repair and ability to make sure that those alleles come out to be exactly the same length. And the MSI test is the best way to find that. So you look at these 5 regions. If only one of these repeat regions is abnormal, we consider that to be basically a normal result. But if there are 2 or more that are abnormal, we call that MSI high. So again, totally different technology, totally different way of looking at the same thing. And both of these tests, IHC and MSI, look for deficient mismatch repair. So although unfortunately the MSI, calling tumors MSI has sort of kind of clouded the waters of what we're actually really talking about. What we're really talking about is deficient mismatch repair. That's really the phenotype we're looking for people with Lynch syndrome. And again, the 2 tests that help you diagnose deficient mismatch repair are IHC and MSI. So one result you could get from IHC is the most normal sort of way that most institutions test for deficient mismatch repair, because almost every pathology lab in the country or the world can do that. You just have to have the stains available. So 80% of the time you're going to get a normal result. All the proteins will be present. The colon cancer then would be MSI stable or mismatch repair proficient. As I say here, the tumors actually that are MSI stable or that are proficient mismatch repair actually overall have a poorer prognosis than the ones that are mismatch repair deficient. So you're generally not going to probably refer someone like this with a normal IHC stain to genetics. But if they were particularly young, or if they had a strong family history or a history of other primaries, you might want to consider that. The second most common result you're going to get is loss of the MLH1 and PMS2. Again, that heterodimer is going to cause both of those proteins to go down at the same time. That doesn't tell you which one has the mutation. But this is going to happen about 15% of the time that you do IHC testing on a colon tumor. This would then be considered a deficient mismatch repair tumor or an MSI high tumor. These have generally a better prognosis because they're MSI high. Most of these are going to be caused from acquired methylation of the MLH1 promoter. So what happens as we think related to age, but probably other things, is that our body aberrantly methylates the promoter region of the MLH1 gene, which causes, again, one of the alleles to be deactivated and then causes a tumor that looks like Lynch syndrome, but actually isn't Lynch syndrome because this only happened in the tumor cell. This was not hereditary. So again, this is very common. There are some of these who have this presentation of the loss of MLH1 and PMS2 on their IHC that will be Lynch syndrome, but again, most of them will not. There's a test that can be done, or actually two tests that can be done to help sort this out. As I say, you can test for a mutation in the BRAF gene called V600E. It's very common. If patients have that, their likelihood of having Lynch syndrome is very low. We can also actually test directly for methylation of the MLH1 promoter. The other result that is more common, but only 3% of the time that you're doing the screening, is loss of MSH2 and MSH6, the other heterodimer. Most of these people, when you find this, are going to be Lynch syndrome, but many of them actually will just be two mutations that occur sporadically in the tumor in these genes. But these, the simple answer is if you see loss of MSH2, MSH6, either or, these should be referred to genetics for a workup because they need to see us to figure out what's going on. Finally, you can see isolated loss of either of these tumors. Generally, again, I would say without harboring too much on this, these are cancers that really should be referred to the genetics group if you can, so you can sort out what's causing this. Many of these will end up being Lynch syndrome. And I forgot to mention, I'm sorry, on the right of the screen of all these, I showed you just some examples of the slide. So here with the loss of MLH1 and MSH2, you see that the tissue sort of looks overall generally grayish, but then the staining is the brownish areas where you see expression of the MSH2 and MSH6 protein, and that's kind of paralleled on all these. The brown or what looks like sort of brownish staining is the normal expression. So many institutions have instituted these universal mismatch repair screening programs, and this is just a diagram that we published a few years ago of what we do here at Fox Chase. And it's been a little modified with time, but this was just to give you an idea and bring up this issue that really the National Comprehensive Cancer Network guidelines and others, EGAP, some of the gynecologic groups and surgical groups now recommend that really every colon cancer patient, every endometrial cancer patient, and really an expanding list of tumors should be screened probably most easily with the IHC testing for Lynch syndrome, because again, this is a common syndrome of colon cancer. It makes up about 2.5% to 3% of all colon cancers that walk through the door. If you have a younger population, it may be even higher. Of endometrial cancer, it's about 2%. Of ovarian, stomach cancer, we're probably talking more like 1%. But even though those numbers may kind of strike you as being small in terms of the genetics world, they're actually really not small. They're very common. And again, by identifying those patients and then getting the word out to family members, you can really prevent a lot of cancers. So again, what we do at Fox Chase, we take those cases, we do initial IHC screening. If the IHC screening is somehow not helpful, we reflex and do MSI. The ones that are deficient, we look at the pattern of staining. If there's the MLH1 PMS2 loss, we'll either do the BRAF testing or methylation testing, which for us is a send out to an outside lab. If it's the loss of MSH2, 6, PMS2, we send those directly for germline testing. And these days, we don't just test for Lynch syndrome, we're often doing a larger panel test on those. So that's kind of my quick summary of Lynch syndrome. I want to cover a little bit as well some of the other polyp syndromes, just to give you a flavor of what those are about. So there are a group of syndromes called the adenomatous polyposis syndromes. That's kind of the next most common group. I won't spend too much time on them, but there is familial adenomatous polyposis. Everyone's sort of heard of that as the poster child polyposis syndrome. You get a colon that is generally chock full of polyps, very high risk of colon cancer. Generally, we will have people remove their colons in their 20s. Because of the high risks. These are from mutations in the APC gene. One important thing really to remember when you're thinking about family history is 30% of these people are not going to have a family history because it's going to be a new mutation in the patient in front of you. So that's called a de novo mutation. You always have to keep in mind that someone who has FAP could have a brand new mutation that they can pass on to their children, but they didn't inherit from their parents. There is an attenuated form of this presentation. It tends to only be a small subset of FAP. They get less adenomas. These people tend to have mutations towards the ends of the gene, either towards the 3' end or 5' end of the gene. But again, generally less polyposis. They don't always need to have a colectomy because their risks are lower. There's a couple other syndromes that are just important to have just awareness of. There's one called MAP, the MUT-YH gene. This is actually one of the few recessive and recessively inherited mutations or syndromes where you get each allele is mutated, and you get a presentation when you get two alleles mutated in an individual that looks a lot like FAP. Actually, carrying one mutation does slightly increase someone's risk of colon cancer to about 2-fold or 10% over a lifetime. And in the guidelines, the current guidelines recommend that those people start colon cancer screening earlier. Finally, there's a newer syndrome out there that has kind of hit the guidelines in the last 3 or 4 years called the POL-D1 syndrome, or PPAP. This is a syndrome that, again, looks a lot like FAP, lots of adenomatous polyposis, other cancers that kind of look like that as well. It seems to be pretty rare in the population. I have to say we're still sort of learning about just how common it is, but it's just one to keep on your radar. Then there's this group of syndromes called the hamartomatous polyposis syndromes, quite a bit rare. You know, you're probably unlikely to see this unless you actually work in a genetics clinic. But Peutz-Jeghers, of course, one we all learn about in med school, but the likelihood of us ever seeing it is pretty small. Really rare syndrome, 1 in 20,000 people or so, but where you can get hamartomatous polyps, and this is a mutation in the STIC11 gene. They have lots of risks of many other cancers as well. Juvenile polyposis, again, super rare. Probably you're not going to see it unless you're in a genetics clinic, but they get these particular, the reason, again, it's called juvenile polyposis is not because it happens in juveniles. It's because the polyp actually itself has a histology that's called the juvenile histology. And so if you ever get a report back from a patient who had a colonoscopy and the pathologist says this polyp is a juvenile polyp, that is a slam dunk instant person who should be sent to genetics, and these people have mutations in the BMPR1A gene and SMAD4 gene. Finally, there's something called serrated polyposis. We've learned a lot in recent years about these flat or kind of more mixed polyps, serrated polyps. If you see these flat polyps, it really is important to probably send them to genetics to get an idea of what they should do with this. The risks are somewhat higher when people have multiple serrated or flat polyps throughout the colon, and I think that is really someone who should have a close consultation. There are also these mixed polyposis syndromes, one caused by GREM1 gene, the other caused by PTEN, which causes Cowden syndrome. Again, if you ever see people who are described as having mixed polyps, particularly one thing that's a big tip-off for Cowden is if you see a patient who is said to have ganglioneuromas on their colonoscopy, again, that should really be someone who gets sent to genetics so that they can be sorted out as to what their risks are. One sort of important question is that's kind of really increased in recent years because of the declining costs of testing and the greater ability to test and these large multi-gene panel tests is you know, what tests should be ordered, and you know, without getting too much in a fuss over what are the best ways to practice. I think what is ultimately emerging in the field is that we are testing for much lower costs, many genes at one time, as really a way to cover sort of all the hereditary risk bases when we see a patient who's at risk. The these multi-gene panel tests can now, for as low as $250, look at up to close to almost 100 genes that are risk genes. Now, some patients may not want to have that, and with genetic counseling, they may want to really focus on what you think is the most likely syndrome. And I think it's very fair if a patient really doesn't sort of want potentially information and risks of finding variants and things they don't really know what to do with in other genes to really focus in one area. But certainly genetic testing has become much more powerful with the ability to sequence and test many genes at one time. And so that is sort of a way that the field is moving. The top of the screen as well points out that with increased sequencing of tumors as well, we are also finding sometimes hereditary mutations or mutations that are suggestive of being hereditary on tumor testing. So I think we all have to read those reports when we test tumors carefully. If you see mutations in genes that are hereditary risk genes, I think it's probably always worth a call to genetics to say, oh, I have a patient who I did a tumor test and they have, for instance, a TP53 mutation. Is that one I should worry about being hereditary or not? What about a BRCA mutation? I think your friendly neighborhood geneticist can guide you on that as to whether that's someone who should be referred or not. And it really varies by gene. One thing I wanted to spend just a second talking about is early onset colon cancer. There's been a lot of buzz around the country about this and around the world. So there's certainly appears to be an increasing incidence of this. And some recent studies have kind of taught us a little bit about at least the genetics of this. So if you test all patients consecutively under 50 with a multi-gene panel test, and some of the nice data of this was done at Ohio State by Heather Hampel's group, you'll find about 16% of people have a germline mutation. Half of those will be Lynch syndrome, but the other half are going to be these moderate to high risk genes, some of which we have classically associated with colon cancer, some of which we haven't, but they all actually have some clinical implications for the patient, including BRCA1, BRCA2, PALB2, ATM. So really, again, the field, especially if you're seeing early onset cases, is moving towards using these multi-gene panels, because even though you may only find some that are kind of expected mutations like Lynch syndrome or the APC gene or MUT-YH that I just talked about, you're going to find these other things that have clear relevance to the patient and family members. So I'm going to just spend a few minutes, because it's already 40 after, just talking a little bit about management. And so I'll fire through these a little more quickly, because this is often stuff that's done a little bit more in the clinic, but this is really, again, to give you a flavor of how we manage these individuals. So again, the guidelines these days for the higher risk MLH1 and MSH2 genes is starting colonoscopy at age 20 to 25 every 1 to 2 years, because these risks are high. They can happen very early in life. And so we have to be sort of as aggressive as we can be. And there are good data to support this. For the MSH6, MSH, and PMS2 genes, we often will advise somewhat later starting and somewhat less intensive screening interval. We are not routinely taking out colons of everyone with Lynch syndrome, because with colonoscopy, you can really do a great job of screening and preventing this disease. The one group that we will sometimes think about that is someone who had one colon cancer early in life and maybe lost part of their colon due to that, and then maybe even despite screening develops another colon cancer or multiple high-grade polyps throughout the colon. So I would say in my practice, maybe once, twice a year, I'm guiding someone to think about doing that. Again, just contrast this to average risk individuals where we start colonoscopy screening at 50, although recent recommendations from the American Cancer Society recommended 45. Also, we generally recommend that African Americans start earlier at 45. So the age is different, and then the interval for the average risk person is 10 years. For Lynch syndrome, again, we're thinking about every 1 to 2 years, or for the lower risk genes, maybe every 2 to 5 years. We generally, there are all these kind of new and fancy technologies out there. And again, I'm not going to spend a lot of time on this, but generally in Lynch syndrome patients, we focus on the colonoscopy as the way to screen these patients, because the problem with many of these newer technologies and tests is they are not validated in high-risk populations. They may not be able to pick up the small polyps that these patients develop or the small polyps that have high-grade dysplasia. So I think, you know, if you're in a bind and you have a patient who really doesn't want to be screened, you know, you may be forced into thinking about using one of these. But generally, for a high-risk patient, I think you really have to think about colonoscopy as your best friend, and you have to have an endoscopist who I think really understands these diseases and knows they have to really spend some extra time looking around their colon and looking for very small lesions that could potentially have high-grade dysplasia in them. There has been some really nice data published back in 2011 looking at aspirin as a preventive agent in Lynch syndrome. We've known for many years that aspirin has benefits in preventing colon cancer in average risk individuals and in people who make polyps, but it was really the CAP2 study that showed us that people who could stick with a pretty substantial dose of aspirin for at least 2 years had pretty substantial benefits with reduced risk of colon cancer and non-colon cancer Lynch syndrome cancers. We have not had a follow-up study yet to confirm why do we need a dose of 600 milligrams per day, which was used in the study. Can we use lower doses? Also just follow up on side effect and toxicity data. But again, this option is out there for your high-risk patients. I kind of go on a patient-by-patient basis when I make this recommendation, and I think hard about things about like how old the patient is, have they ever had a risk of bruising or GI bleeding, are they thinking about getting pregnant in the future? Different variables like that help me decide whether aspirin is the right thing for them or not, but clearly there are some benefits. Most of the data in Lynch syndrome really focus on colon cancer prevention, and anyone in the field will tell you that you know, we sit around a table a couple times a year or on the phone and really sort of pick over the data and try to think about making the best recommendations we can, but they are often not based on randomized control trials. These are really based on how we interpret epidemiologic data and secondary data otherwise. So uterine cancer, we generally recommend some assessment by a skilled gynecologic oncologist, uterine biopsy, sometimes in women who are premenopausal who still might want to have children, and consideration of total abdominal hysterectomy when they are done childbearing, also oophorectomy. But again, these are not based on randomized controlled trials as a way of preventing cancer. Also, just to, and I'll say this in a minute, some of the guidelines have softened a little bit. One thing that I think many people in the field have started to evolve on and be a little more vigilant about is that you know, there are a lot of skin manifestations of Lynch syndrome, and the data show that probably about 20%, maybe up to 1/4% of people with Lynch syndrome will have manifestations on the skin, many of which are sometimes probably missed by providers. So probably everyone with Lynch syndrome over their life should from time to time go see a dermatologist and have a good look over to see if there are things. These individuals with Lynch syndrome can get something called sebaceous adenomas. They can get some other rare skin manifestations. So I think it's important that people think about doing that. Again, with endometrial and ovarian cancer prevention, with the help of our colleagues in gynecologic oncology, some of our guidelines have really evolved. So total abdominal hysterectomy, which used to be sort of a definitely do once childbearing is done, now the guidelines have softened a little bit to say it's an option. There's no mortality benefit, but it may help lower incidence of endometrial cancer. Oophorectomy as well may reduce the incidence of ovarian cancer, but again, with some new data on the prevalence of ovarian cancer with the different genes, we sort of have had some modifications to the guidelines about which genes are higher risk, and it does appear that MSH2 gene appears to be the highest risk for ovarian. But unfortunately, again, there's no effective screening for especially ovarian cancer, so many women do, of course, choose when they're done childbearing to have their ovaries taken out. I think the other thing you always have to remember in the risk business is that you know, the ovaries do more than just make oocytes to potentially produce children. They produce hormones that protect women from bone disease and heart disease. So you have to be really thoughtful about if you're going to take ovaries out when you do it, because you, especially in the premenopausal women, may instantly start to put her at risk of bone fracturing and cardiovascular disease and vaginal dryness and many other things by removing the estrogen source. Gastric cancer, again, no great randomized data about this, but one thing that's been reassuring in the US and other westernized countries is that even it appears in Lynch syndrome and the general population risks have gone down. This is probably because of better storage of the food supply. Foods are fresher, less likely to have bacteria in them. Also, the Western population has declining rates of H. pylori. The groups that we do still tend to recommend more sort of vigilant gastric cancer screening are the Lynch syndrome families where we see cases of gastric cancer or multiple cases, and Asian populations that have Lynch syndrome. MLH1 and MSH2 appear to be the highest risk genes, but again, I've certainly seen gastric cancers in the other two genes as well. These tend to not be sort of the diffuse gastric cancers. They tend to be intestinal type. We often see them in older Lynch syndrome patients. They tend to be lymph node negative, larger tumors that have tumor infiltrating lymphocytes. And again, with the emergence of immunotherapy, many of these can be treated effectively with immunotherapy, which is really exciting. Definitely, though, if on screening for gastric cancer and Lynch syndrome, if H. pylori is found, we would recommend that be treated. That's kind of a no-brainer at this point in the U.S. Again, skin screening, just to make the point that there is a group of people, anywhere from 10 to 20% with Lynch syndrome, who have manifestations on the skin. We call those group of people Muir-Torre variant Lynch syndrome. Again, we associate this mostly with the MSH2 gene, but yet we know that all the other genes can get this, and they can get a variety of things that, you know, the average primary care doctor may not recognize. So I'm generally more aggressive in recent years of sending at least sort of once or every few years, sending my Lynch syndrome patients to see a dermatologist just for a good look over, because people can get these things that, even though they're not likely to kill a patient, they can be very large. They can affect areas of the body that are hard to resect, and you want to get them off early if you can. So that's all I have to say at that part, and I think I just have a couple more slides. This is actually stuff that I was going to cover for a different talk. So that was what I had to say. I'm going to turn on the question and answer. If anyone does have any questions and answers, I guess you can kind of type those in, and then I can answer them. So I think I opened my little thing, so hopefully it works. I don't know if my hostess is still here, but I guess if we don't get any questions, everyone's welcome to email me if they have some questions they don't want to publicly post. I'm totally fine with that. So I'll just give you my email. My email is Michael, M-I-C-H-A-E-L, _Hall, H-A-L-L, at FCCC, as in Fox Chase Cancer Center, ccc.edu. I'm always interested and happy to help answer your questions. If you ever have any patients that you have questions about or need help or would like them to see a genetics group, we have a robust group. We also have lots of research going on in these individuals. So if you have patients who are already identified who might want to participate in research, we would love to have them. We also participate not only in some national research studies, but some international studies putting together Lynch syndrome families to, again, better define penetrance with each of these genes and which genes are associated with which cancer. So for all those reasons, we're glad to help you out and see your patients and enroll them in research if you want. If there's no questions, again, it was my pleasure. I hope people learned something, and I'll be happy to get your emails if you have any. Thanks.